Welcome, friends, to today's She and Right session on the theme of Connecting the Dots, HIV, Sexual and Reproductive Health Rights and Justice, and the Sustainable Development Goals. This session is jointly organized by Global Center for Health Diplomacy and Inclusion, that is SEDI, International Conference on Family Planning, ICFP 2025, Family Planning News Network, FPNN, International Planned Parenthood Federation, IPPF, Asian Pacific Resource and Research Center for Women, ARROW, Women's Global Network for Reproductive Rights, WGNRR, Asia Pacific Media Alliance for Health and Development, APCAT Media, and CNS. Those media persons who are reporting on issues raised by She and Rights, please be welcome to apply for She and Rights Media Awards 2025. The link to apply is given in the chat box. And thanks to SEDI, the first prize winners from Asia Pacific and African regions will get to go to ICFP 2025 in Colombia. Friends, as we know, the United Nations Intergovernmental High-Level Political Forum, or HLPF 2025, has just concluded with a review of SDG 3 and SDG 5 and few other SDGs. Also, the 13th International AIDS Society Conference on HIV Science, or IAS 2025, ended a week ago in Rwanda. And the UNAIDS Global AIDS Updates 2025 were released a few days ago too. Prior to HLPF, the 4th Financing for Development Conference, or FFD4, had clearly failed to deliver on gender equality and the feminist agenda. In fact, it was even a setback to previous FFDs held in Monterrey, Mexico in 2002, in Doha, Qatar in 2008, and Addis Ababa, Ethiopia in 2015. FFD4 outcome document also compromised the International Conference on Population and Development, ICPD 1994, and its Program for Action, as well as the Beijing Declaration and its Platform for Action 1995 commitments. Let us dive deeper on how the progress or lack of it is impacting sexual and reproductive health rights and justice of people in the Global South, along with the latest HIV updates from the UNAIDS with data released 2 weeks ago. A few quick housekeeping announcements. Participants, please keep yourself muted throughout the session. You can type in your queries and comments in the chat box as the session progresses. We will take up all relevant questions after all the speakers have presented. Without any further ado, I invite our opening keynote speaker and our friend and mentor and guide, Eamonn Murphy, to give his keynote address. Eamonn, as we know, is UNAIDS Director for Asia and the Pacific, Central Asia, and Eastern Europe regions. Welcome, Eamonn. Over to you.
Thank you very much. It's a great privilege to be here with so many colleagues from across the world, different parts of the world, looking at these common issues. So thank you very much, Shobha, for inviting me to speak. The topic today is critical, the intersectionality of all these issues. Each separately is under challenge, the greatest challenge that we've faced in some of these areas because of political and financial changes that have impacted. So we need to be looking outside our individual silos and be looking at the intersectionality of all of these issues. So it's a recognition of the importance of this, that the topic has been broadened to such a degree, and the importance for us to look, how do we adjust? How do we connect? How do we identify the synergies, the common issues that we want to work on together? And that's going to be critical for us as we move forward. If I could have the next slide, please. Data from the new report that was just mentioned, our UNAIDS report, AIDS, Crisis and the Power to Transform, amounts to a warning for the world. We are in a unique situation. Historic funding crisis is threatening to unravel decades of the HIV response and related issues that it is supported. Unless countries make radical programming and funding shifts, we will lose a race that we should have won. Now, these graphs that you see here are not yet a reality. The orange lines are 5-year projections based on available data for new infections and AIDS-related deaths globally if the lost funding does not return. Transformation and mortality could climb to levels we haven't seen for 20 years. Now, this, I need to be clear, is not a criticism of any one donor. Many donors have been reducing their investments in public health, other justice areas and rights areas, and HIV. And then recently, of course, we all know of significant reductions in funding that have a sharp impact on all of these areas and more. But at the same time, domestic funding that should have been increasing over the years with the knowledge of AIDS is not going to go away unless it's sustainable and owned as an issue, just like the other issues in sexual reproductive health. This funding domestically is inadequate or targeting the wrong areas. So these graphs are a reckoning. This point in time for us all is a reckoning for everybody. Most countries have funded some relevant parts, but not others in their responses. And so this has been the challenge. With every scientific innovation, we have to advocate again for access for all. And we're seeing that with the new long-acting treatments and prevention commodities. They're not available in every region of the world. There's going to be targeting. The cost is about $28,000 US per year in advanced economies. So nobody can afford that in the rest of the world. Even with the offers from the manufacturers, we're not going to get there anytime soon. We need it in generic form out in countries as quick as possible. It can be down to $40 per year per person easily, or even more, depending on the scale. Some projections show it could be as cheap as $25 a year per person. That's a significant difference for treatment and prevention of HIV. But sadly, this year, we've also seen in the report that criminalization of key populations has actually increased. This is significant for all key populations and for women, and I'll touch on that later. We have a small window of opportunity to correct course. Next slide, please. Even before these funding cuts, we knew that the issues, the pace of progress did not match the feasible ambitions. The issues were not being addressed in the right ways, in the right places. And this graph here shows that we have growing epidemics in 3 regions. These include the regions that I support, Eastern Europe and Central Asia, where there has been a 7% increase since 2010. And new infections have declined by just 17% in Asia Pacific. And this is a significant problem because we have fast-growing epidemics in some countries, whilst we have solid progress in others. But overall, the momentum has virtually stalled in Asia Pacific. Globally, the figures are at 40+% reduction, but we're not seeing that in this region with one of the most obviously populous regions of the world. And a quarter of new infections occurring in Asia Pacific alone. We urgently need a prevention revolution, but one that is anchored in rights and social justice, and also interconnecting with the other issues that are also compounded by the challenges that people face in accessing services for sexual and reproductive health, for services that are tailored to particular parts of the population, women having the access to the services they need early so they can take control of their lives. Next slide, please. This graph shows in both regions, HIV prevalence is significantly higher among key populations. Asia Pacific is to the left, and Eastern Europe and Central Asia is to the right. At the far right of each graph, you see the low median adult HIV rate. But compare this to the far higher prevalence in sex workers, in men who have sex with men, people who inject drugs, transgender people, and people in detention. In 2022 in Asia Pacific, 4 out of every 5 new infections were among key populations and their sexual partners. In most of these cases, 43% were in men who have sex with men. We also have rising numbers in many countries that were having great success in stabilizing the epidemic. The rise is amongst young people. And so their issues are different to the way that the older epidemic, if you like, was responded to and addressed. So we're going to have to see some significant shifts in how to reach and meet the needs of young people today that are very different to others. In Eastern Europe and Central Asia, 94% of new infections were among key populations and their sexual partners. And there are variations between these two regions. The issue of migration is significant in Eastern Europe and Central Asia, where women are often at high risk because of their husbands and partners who are traveling overseas for work and coming back intermittently, and unfortunately sometimes infecting them with HIV, which they don't know about until they access health services, and then they are blamed for this. 1/3 of new infections were in this region were among clients of sex workers, and over 1/4 of new infections among people who inject drugs. But the shift is very much from drug use to sexual transmission. Again, the importance for the intersection and addressing other issues in sexual and reproductive health. In some of the more mature epidemics across the globe, we've seen an increase in the proportion of new infections among the general population. This is a cautionary tale for us of what happens when we ignore key populations in our service programs. Their issues are important and need to be addressed, even as you see a shift in other parts of the population, or else the issues just keep growing. The problem doesn't disappear. It grows in different parts of the community. So a piecemeal response is not going to work. Next slide, please. Stigma and discrimination and poor health service results, including for HIV, are a critical and obvious thing that we all know about, right? And we'll hear that from other speakers today. A challenge here is in society, people in Eastern Europe and Central Asia, 48% death rates. This is because people are coming in with advanced stage illness. We're seeing that in a number of other countries in Asia Pacific, the Philippines, Indonesia, where we have far too high a death rate in this stage of the response to HIV, and with the treatments that are available and the testing diagnostics that should be able to support early diagnosis, early engagement in treatment, and then the success of viral suppression, which leads us to U equals U. It stops forward sexual transmission, but we're not seeing those benefits because of stigma and discrimination. This is a median aggregate on the slide of available data just from the Asia Pacific countries. So in the last year, 28% of transgender people, 20% of people who use drugs, and 18% of sex workers, and 7% of men who have sex with men avoided healthcare services due to stigma and discrimination. In many countries, this data is not gathered, and that's part of the problem when you're identifying, or it's not reported. And so programs in each country need to be addressing what are the barriers that are keeping people away from services. In parts of Eastern Europe and Central Asia, criminalization of the transmission or risk of transmission of HIV is still actively used. So the example I gave earlier, a pregnant woman going into antenatal care, finding out she is HIV positive and potentially transmitting HIV to her child, she's unknowingly, because her husband, her partner, is a migrant worker. Now, she then faces criminalization and court. So this is an unfair and totally unnecessary approach. And will it encourage people to go to services if they think they're at risk of HIV? This is one of the challenges. Where we criminalize, we see a reduction in engagement with prevention and with treatment services, and that just helps grow the epidemic. Just like people living with HIV, key populations avoid or delay accessing health services that are unfriendly or where their rights to respect, to dignity, and importantly, confidentiality are violated. If you're afraid the community, your employer, your family are going to find out either that you have HIV or maybe how you acquired it, you're going to avoid the services that are available. And this is why community services that provide more confidentiality are critically important and need to be resourced by governments in implementing the service delivery. Again, we're reminded that this is fundamentally a rights and social justice mission. Again, the intersection. It's not just a treatment, just a biomedical approach. We have to be looking at all these different issues. We must do better of partnering together to address the structural factors that will lower the impact and increase the reach of the services to the people who need them early on in their HIV stages. Next slide, please. In the standalone regional chapters of this year's report, we have testing and treatment cascades for children, for women and men. The graphs to the top are from Asia Pacific and those at the bottom from Eastern Europe and Central Asia. Forgive me, of course, I'm focusing on these two regions because they're the regions I support and have worked with over the last 20 or so years. As you can see, women have the highest diagnosis and treatment rates. Men have significantly lower coverage. So we must respond to the gender dynamics at play in different parts of these regions and the world at large. So this means working with other sectors to address the broader challenges like increasing health-seeking behavior, especially early on among men, and facilitating their access. Looking at the unique issues about what keeps them away from accessing services, and if they're kept away from it, it places other people, including women and their other sexual partners, at risk. We must also address these intersecting risks so that people who use drugs, men who have sex with men, can safely access the services they need. They must be available to these people to help prevent HIV and other diseases whilst dealing with other issues that they're looking at in their lives and facing challenges in acceptance in society. So our HIV results to improve require broader action. Next slide, please. But we should not interpret higher service coverage for women to mean that they themselves are without challenges. In different parts of the world, the impact on women is much higher than in other parts. In individual countries, there are a range of different issues that are affecting. But violence, and particularly intimate partner violence, increases women's risk of contracting HIV. This is a significant issue in many parts of the world. Women living with HIV are also more vulnerable to abuse. These graphs show that in countries with available data in both of our regions, there are high levels of recent intimate partner violence. I gave the earlier example also where women are faced with criminalization, often which doesn't occur to the husband or the partner who's already predeceased or is overseas. Here we will see in the next slide that all over the world, women living with HIV still experience coercion, abuse, and mistreatment when accessing sexual and reproductive health services. 5 of the Eastern Europe and Central Asia countries are included alongside examples here in this slide from other regions. And note the extremely high levels in Kazakhstan and Kyrgyzstan. So significant issues in those epidemics, in those countries that need to be addressed that are different to other parts of the regions. So the different programs need to be tailored to recognize the realities of women in these countries. Next slide, please. I'd like to take a break from the data and talk about some of the realities, the real people that we are trying to support, to reach, and allow them to lead respectful lives, fully engaged within their communities in all ways. The first is Eva Dewa, and she's from Indonesia. In 2017, she learned she was HIV positive. We have permission from both these people to share their stories, and they have shared these themselves publicly. When she went home and told her husband in 2017, he blamed and abused her. She had given birth to twins 2 years before her diagnosis. She was not offered an HIV test during any of those antenatal care visits that she had undertaken. She had a normal delivery and breastfed both children. When she later learned her status, the clinic did not suggest that her children be tested, but she chose to do so. One twin was HIV negative, the other was not. The other woman who shared her story is Takmina Haydarova, who's from Tajikistan. She was raised in a traditional household and married a man who worked abroad and rarely came home. During a routine checkup, she learned she was living with HIV. She had absolutely no information and support. Her husband rejected her, and his family blamed her after he died due to an AIDS-related cause. The reality for far too many women is violence, stigma, and HIV services, which are divorced from the other types of healthcare that they normally receive. So we need to be looking at integration. We need to be looking at not separating all the different services into silos so that people can be easily identified if they go to an HIV clinic, where it should be integrated into other services for women or other people who need them. Next slide, please. Our next global AIDS strategy comes at this complex and challenging moment in the response for public health, and particularly the response for HIV and sexual health and reproductive health services. Over the last several months, we've held many consultations with partners to determine what's the best way forward. And we're going to have in the new Global AIDS strategy much more of a regionalization approach to show what are the differences in different parts of the world that need to be addressed today. The epidemics and the progress to the epidemics is very different in different parts of the world. So far, we have 5 umbrella recommendations that are relevant to both regions. So I'd like to share these with you briefly. First, there must be a laser focus on key populations to reduce new infections and to stop the spread into other parts of society. This means investing at scale in relevant and innovative prevention services, especially community-led approaches that allow people to avoid some of the stigma and discrimination that they may feel they will receive in other services, and make it safer and friendlier for them, which will encourage them to access services. It's also about when they need to access it. Often it's not during the standard working hours, it's evenings or weekends or online. People should have prevention options that fit their lives, the full range of PrEP choices and condoms, for example. The DVR, the new ring that's identified, also needs to be a part of the mix. People need to make the right choices that fit their lives and their contexts. We must also prepare for the adoption of the long-acting technologies that I mentioned earlier, both in cost and having them available, but in a sustainable way. We need governments to start looking at the issue of sustainability much more than they have in the past. It was talked about, but often left aside because there were international funding available, but we're seeing the sharp decline in those, and we'll see more in the next couple of years ahead that is going to have an impact. So we need to look at sustainability of prevention, not just of treatment. Using a people-centered approach, we should integrate services, getting the most out of every interaction and investment. Make it easier for people to access the range of services they need and not separate these and make it more complicated, and therefore people just don't follow through. Resources for this work need to increase and be prioritized over the often ineffective general population prevention approaches that we still see in places where we have key population epidemics. Second, community leadership is a non-negotiable. This is leadership in all forms, leadership and implementation of programs. So social contracting, where we see great examples of it in a whole range of countries, India, Thailand, in other parts of the world, where it's working effectively. And governments are saving money by partnering with those who are able to access and reach and support the people who are most in need of these services. Community work must be fully integrated, resourced, and enabled as a central pillar of the health response, not just for HIV, but other areas. Sexual reproductive health would be an obvious one as well. We see this in the whole area of TB as well. Not engaging the community effectively limits it. And there's a co-infection issue and morbidity and mortality with TB and HIV intersections. So to do this, we must create the legal and policy space for communities to do their work, including inclusive governance, sustained funding, and community-led accountability. Critically throughout this, we need to make sure there's support for organizations of women living with HIV or at risk of HIV, because in some places where there are higher new infections amongst men, the women who are becoming infected are often overlooked, and this is not equitable. We need to do better on this. Third, countries should do a better job at using the programmatic, the epidemic, and financial data to determine resource allocation for more impactful responses. Where there's a high investment in treatment and an almost impossibly low investment domestically in prevention, we're not going to end HIV as a public health threat. We are just playing with the puddle whilst the tap is running above it, and we're not targeting the resources effectively. Our fourth recommendation is for expanded treatment access in underserved countries and locations. So in doing so, governments must take into account budget gaps due to the reduced donor investments today and those that are coming in the next year or two. The region should also explore pooled procurement options. Middle-income countries, the cost of treatments and commodities goes up, so they need to look at new ways to make it more effective by larger procurements together. Finally, sustainability is required to ensure both the policy and the programmatic priorities are funded into the future. It's not just a financial sustainability, it's making sure we've got the right programs in place to make them sustainable as well, and the right partnership with community. We need accelerated domestic resource mobilization strategies and strategies for leveraging the private sector as the way forward. Malaysia is a great example of doing this. A third of the funding for their response is coming from the private sector in partnership with government and communities. We also need a strategy to maintain critical external financing where possible. Friends, these are not groundbreaking ideas. We've heard them before. It's what we should have been doing more of earlier. But there was a reliance on external funding and the assumption that some of the big structures would be with us for longer. Now that the clock is ticking on the goal to end AIDS as a public health threat by 2030, we need to finally invest in people-centered, gender-sensitive, and evidence-based responses. But equally critical is bringing the various programs and looking at where there's a synergy and interconnectedness to reduce resources and make them more collectively impactful and effective in reducing infections of all sorts, not just for HIV, and making people's lives better. Thanks very much, and back to you, Shobha.
Thank you very much, Eamonn, for such a lucid presentation of the latest UNAIDS data, and also for your very valuable recommendations, including the increasing targeted domestic funding, and also that prevention services should be anchored in human rights, and they should be community-led, especially in key populations. Thank you very much for your time. I now welcome our next speaker, Letlhogonolo Mokgoroane, I hope I'm pronouncing the name correctly, to share perspectives from the African region in the context of our session's thematic focus. Mokgoroane is a legal representative and head of strategic litigation and research, OurEquity, South Africa. There is also a member of Johannesburg Society of Advocates. Welcome, Letlhogonolo. Over to you.
Thank you so much. I hope everyone can hear me.
Yes, very clear. Thank you.
Thank you. I just wanted to start by saying thank you for this wonderful opportunity to join this really important webinar. We're talking about connecting the dots, HIV, sexual reproductive health, rights and justice, and sustainable development goals for Africa. Distinguished guests, colleagues, and friends, thank you for the opportunity to speak to you today on a topic that is not only timely, but also critical for the future of our continent. Connecting the dots between HIV, sexual and reproductive health, rights and justice, and the sustainable development goals for Africa. Let us begin by acknowledging the progress that we've made. Over the past decade, Africa has seen remarkable advances against the fight against HIV. According to UNAIDS, new infections in Eastern and Southern Africa declined by 57% between 2010 and 2023. Over 20 million people in sub-Saharan Africa are accessing antiretroviral viruses, a testament to the commitments of governments, communities, and international partners. Yet despite these gains, the journey is far from over. In 2024 alone, there were an estimate of 800,000 new infections in sub-Saharan Africa, and women and girls accounted for 63% of these. Adolescent girls and young women aged 15 to 24 are more than twice as likely to acquire HIV than their male counterparts. These numbers remind us that HIV remains a public health crisis. But HIV is not just a medical issue. It is deeply intertwined with social, economic, and legal factors. To truly end HIV as a public health threat, we must look beyond the virus itself and address the broader context in which it thrives. This brings us to the heart of today's discussion, the intersection of HIV with sexual and reproductive health rights, justice, and the Sustainable Development Goals. First, let's talk about sexual and reproductive health rights. Sexual and reproductive health and rights is more than just about accessing contraceptives or maternal care. It is about the right of every individual to make informed decisions about their body, free from violence, coercion, or discrimination. When people, especially women and girls, are denied these rights, they become more vulnerable to HIV and other health threats. For example, only 40% of young women in sub-Saharan Africa have comprehensive knowledge about HIV prevention. In some countries, less than 50% of women have access to modern contraceptives. Gender-based violence remains alarmingly prevalent. In South Africa, a woman is killed every 3 hours, and 1 in 3 women have experienced intimate partner violence, and survivors of violence are targeted. Survivors of violence are at 50% risk of acquiring HIV. Just one moment for me, please. Let's talk. Criminalization of same-sex relationships and sex workers drives people underground, away from essential health services. In 31 African countries, same-sex relations are still criminalized, making it difficult for LGBTIQ+ individuals to access HIV prevention and care. Sex workers, who are 13 times more likely to be living with HIV than the general population, often face harassment, violence, further increasing their vulnerability. Justice is central to this conversation. Laws and policies that discriminate against people living with HIV, LGBTIQ+ individuals and sex workers, and other marginalized groups not only violate human rights, but also fuel the epidemic. For example, in Nigeria, the Same-Sex Marriage Prohibition Act has led to 41% decrease in access to HIV services among men who have sex with men. Justice means ensuring that everyone, regardless of who they are or whom they love, can access the information, services, and support they need to live healthy, fulfilling lives. Now let's connect these issues to Sustainable Development Goals. The Sustainable Development Goals provides a roadmap for a better, more equitable world by 2030. We're just 5 years shy from that. Goal 3 calls for good health and well-being, including ending the AIDS pandemic. But achieving this goal is also impossible without progress on other goals, such as Goal 5, which is gender equality, Goal 10, reduced inequalities, Goal 16, peace, justice, and strong institution. Each of these goals is interconnected. For example, studies have shown that countries with high gender equality have lower rates of HIV infections among women. In Botswana, legal reforms to protect women's property rights have led to increased economic independence and better health outcomes. We can't achieve health without justice. We cannot achieve justice without upholding rights. And we cannot uphold rights without addressing the root causes of inequality and exclusion. So what does this mean for us as policymakers, advocates, health workers, and community leaders? It means we must break the silos. HIV programs cannot operate in isolation from broader sexual and reproductive health services. Legal reforms must go hand in hand with public health initiatives. We must listen to and empower those most affected, young people, women, LGBTIQ plus communities, and people living with HIV to lead the way. It means investing in education, not just about HIV, but about consent, healthy relationships, and bodily autonomy. In Uganda, the DREAMS initiative, which combines HIV prevention with education and economic empowerment for adolescent girls, has reduced new infections amongst participants by 25%. Supporting community-based organizations is crucial. In Kenya, peer-led outreach among sex workers have doubled the uptake of HIV testing and treatment. It means holding governments accountable for their commitment to human rights and the Sustainable Development Goals. In 2023, only 16 African countries have fully funded their national HIV response. We must advocate for increased domestic investment and international solidarity. And it also means recognizing that justice is not just a legal concept, it is a lived reality. When a young woman can access contraceptives without fear, when a gay person can seek HIV testing without shame, when a sex worker can report violence without risking arrest, we're moving closer to justice. In conclusion, let's remember, ending HIV in Africa is possible. Achieving sexual and reproductive health rights and rights for all is possible. Realizing justice and sustainable development goals is possible, but only if we connect the dots across sectors, across communities, across our shared humanity. Let us work together, not just for an AIDS-free generation, but for a future where every person in Africa can live with health, dignity, and justice. Thank you.
Thank you very much. And amen to what you said in the last sentence, that every person in Africa, and I'm sure you mean the rest of the world in the entire global south, lives with dignity and rights. Thank you so much. Can we have a short form for your name, if or
you can just call me Al if it's just say Al.
L.
Yes.
Okay. Thank you, Al. Thank you very much. Our next speaker for today is Dr. Angelique Nixon. Dr. Nixon serves as Director of CAISO, Sex and Gender Justice, and is a senior lecturer at the Institute for Gender and Development Studies, the University of West Indies, at the St. Augustine campus in Trinidad and Tobago. She will share with us the latest updates on recriminalization of same-sex and gender-diverse communities in Trinidad and Tobago and other perspectives from the Caribbean and Latin American region. Welcome, Angelique, and special thanks for joining us at this, as this would be so early today for you in the morning. Over to you.
Thank you so much. Can you all hear me?
Yes, very clearly. Yes.
Okay, wonderful. Good morning, everyone. And yes, it is quite early here. I hope you, yes. Okay, I'm gonna just dive in. I know I only have 8 minutes. I wanted to first just share some information about and perspectives about the moment that we're in terms of the anti-gender and anti-rights moment. And these are really manifesting themselves across sexual and reproductive health and rights work, across the fields of gender and sexuality studies, and has had a direct impact in terms of my work, teaching and research in gender and development studies and sexuality studies, to the work that I do in gender and sexual justice movements and LGBTQI plus activism more broadly. And these movements are part of larger anti-rights movements that have attacked social justice advancements and offered and fueled really a backlash against progressive social and environmental justice movements. They perpetuate false and misleading narratives about gender, sex, sexuality, human rights, and climate change. These anti-gender movements have fueled trans panic and anti-LGBTQI sentiments and homophobic and transphobic attitudes and discourses globally. These negatively impact public understandings of gender and sexuality LGBTQI plus identities, and sexual and reproductive rights, especially all of these things being connected. So connecting the dots and thinking about the ways that these anti-gender and anti-rights moments have affected our work. And of course, this has drastic effects for how we, of all movements and advancement on gender equality, which of course affects sexual and reproductive health and rights and has direct impacts, of course, on HIV. These are driven by political, conservative, and religious bodies that frame understandings of gender as a threat to the social good. And so increasingly, it seems that any progressive position on justice, whether it's social, racial, gender, sexual, economic, migrant, disability, climate, or ecological, is understood as threatening and destructive to the dominant global order. And particularly for those of us in the global south, we have to understand and think through and make very clear that this global order is white supremacist, capitalist patriarchy that sustains itself through division, fear-mongering, and beliefs that a market will fix anything and will fix everything, and we know that it does not. And so these movements have influenced public discourse and legislation and restrict human rights and spread fear-based narratives. And of course, I don't need to say it, but this moment is being escalated by the dizzying government actions in the United States that have global impacts. And I won't go into all of those, but it's a really incredibly frightening and dangerous time where we're seeing a push to far-right leaning politics that have very similar tenets of being anti-rights, anti-migrant, anti-gender, and in climate change denial. And I'm connecting those dots because they have direct impacts on health systems. And so in the Caribbean specifically, and this is also across our region, Latin America, we see how these anti-rights and anti-gender movements fuel conservative religious perspectives that emerge from colonial era gender and sexual norms and laws. And they also oppose the movements to decriminalize them. And so LGBTQI plus discrimination and stigma have been exacerbated by US-based Catholic and evangelical organizations who've poured resources into the Caribbean and Latin America with the goal of promoting an anti-LGBTQ plus ideologies and preventing gender equity advancements. And this has been going on for years. I think that's important to know that this has been happening for a decade and more. They utilize financial resources, cultural clout, and fear again. And these movements maintain social and political power and they attempt to obstruct developments that would challenge their ideological stance. And more specifically, Global North conservative organizations such as Agenda Europe and the World Congress of Families have funded anti-gender movements and laws internationally and held conferences in the Caribbean, namely in Trinidad and Tobago and Barbados. Their agendas include opposition to divorce, birth control, same-sex marriage, pornography, and abortion. In the Caribbean, anti-gender movements have blocked the provision of comprehensive sexuality education and intensified violence against LGBTQI plus people and limited access to sexual and reproductive health care. In Trinidad and Tobago, in 2018, the decriminalization judgment was successful. The High Court insisted that same-sex sexual practices that are consensual should be not against the law, and that it was in fact a constitutional against one's constitutional rights. But we waited for 6 years for changes. The government decided to appeal that process and to appeal the High Court judgment. And during those 6 years, there's been no meaningful protections. The government did not advance any changes in law, and there were no advancements on LGBTQI plus rights. Meanwhile, over the last 6 years across the Eastern Caribbean, there has been various successes in being able to advance decrim. And in Barbados in particular, there's even been protection in the workplace based on sexual orientation. However, in Trinidad and Tobago, we have just witnessed the overturning of the landmark 2018 High Court decision regarding the decriminalization of same-sex sexual activities. And in fact, the Sexual Offenses Act, they modified in the appeal court. And so now we have what we are calling and understand as a recriminalization of consensual same-sex acts, and they have been made illegal again, although the punishment was reduced in some cases. Now, this is all complicated because the state's central argument in the appeal was that these sections were considered saved law and therefore protected from being struck down by the courts. Now, the appeal court agreed that the sections are indeed saved, and therefore they overturned this judgment. However, the appeal court judges agreed that sections 13 and 16 of the Sexual Offenses Act are discriminatory. But the court insisted, they have to yield to Parliament to make these necessary amendments through legislative reform, because the court interprets the law and only Parliament can change the law. So we are stuck in a colonial conundrum, if you will. This latest court ruling in Trinidad and Tobago is a grave, disappointing, and devastating blow to human rights broadly, and it has far-reaching impacts on how we protect rights, citizenship, and people who are marginalized, especially in the context of this anti-gender and anti-rights moment that we are in. Of course, there are fears here around, since this happened in March, the increase and the possibility of more violence against LGBTQI plus people, especially those who are already vulnerable because of intersecting issues, from structural discrimination to family violence to lack of opportunities and less access to resources. Some of the ongoing issues that LGBTQI plus people face living in Trinidad and Tobago include all of these, family violence being one in particular that has been happening for years, housing and food insecurity, unemployment, and a lack of access to needed social services. This includes sexual and reproductive health and rights. And we also recognize in our work, and I will say a little bit about CAISO now in my last moments here, that CAISO Section Gender Justice, we've been collecting data and insights on the violations experienced by LGBTQI plus people since 2020 through our Wholeness and Justice program. I'll share some links here for you when I'm done. And in our most recent report at the end of 2024, we highlighted a lot of the intersecting issues that our community members experience. We respond to violations, and precisely because the community remained at risk of discrimination and violence, even with the 2018 landmark judgment. And with the government making it clear that they would not enact any changes, meaningful changes or protections, we built the Wholeness and Justice program to engage in strategic litigation and to fill in glaring gaps in legislation and social service provision that impact our community members daily. So I'm putting all of that into context so that we can understand when we were connecting the dots for us in Trinidad and Tobago, and I think also across the Caribbean, we have to address the intersecting experiences of queer and trans people, especially. We have to think about these larger contexts. And over the last 5 years, our work has focused on evidence-based advocacy. We're informed by the provision of legal and psychosocial services for LGBTQI plus people. And our advocacy also includes public education, training, community support, and outreach. And just to say that all of this work is so necessary for creating change and transforming some of the harmful social and cultural norms that give rise to discrimination, violence, and homo, queer, and transphobias. And so our work has to be feminist, decolonial, and rooted in cultural transformation. And I will say in closing that when we talk about the recriminalization, that we have to understand that this is a consequence of our colonial past. We also have to understand that when we work to the interpretations of the laws and the situation that we find ourselves in, is that we have to decolonize our legal systems and other institutions, and this is an urgent priority. And so I will pause there for questions. I see I say that my time is up, and I hope to share a little bit more about these issues during our Q&A. Thank you.
Thank you, Angelique. Thank you very much for bringing to the fore about how anti-rights and anti-gender activities are on the rise, and they are directly impacting the health rights of women and gender diverse communities. And we need to be very, very wary of them, and also all force to the great work people like you are doing to actually contradict and get rid of such ideas which are being formulated by the right wing governments all across the world, global south as well as spearheaded from the global north. Moving forward, I would like to invite Pam Ntshekula, Lobbyist Officer with SWET, that is Sex Workers Education and Advocacy Taskforce of South Africa. Pam is a dedicated advocate for the rights and safety of sex workers. Pam, please can you share your insights on the progress or the lack of it in the context of SDG 3 and SDG 5 for sex workers and communities? Over to you.
Thank you so much. Sorry, let me fix my camera a little bit. Good afternoon, everyone. My name is Pam Ntshekula, but I prefer to be called Pam. I'm a lobbyist officer at SWET, as you said, the Sex Workers Education and Advocacy Task Force. Our work is focused on advocating for the full decriminalization of sex work in South Africa. We work directly with sex workers on the ground through outreach, peer education, and community mobilization. A big part of what we do is policy, lobbying, and advocacy, pushing for laws that protect sex workers' rights, health, and safety. Our mission is clear. Sex workers deserve dignity, protection, and full recognition of their human rights. We're calling for the full decriminalization of sex work because sex workers deserve to work in safe, free, and dignified spaces. Right now, criminalization puts sex workers at risk. It makes them more vulnerable to violence, police abuse, stigma, and poor health access. Decriminalization would mean sex workers can report crimes without fear, access healthcare without judgment, and work without hiding. Sorry, I have, my camera has been taking. Can you all see me? Am I still in camera?
Yes, we can see you very clearly.
Okay.
Yes.
Okay, thank you. It's not just a legal issue, it's about human rights, health, and safety. Every sex worker deserves to be protected and respected, free to choose on how they live and work. So now, speaking with SDG 3, which is good health and well-being, it obviously ensures healthy lives and promote well-being of all at all ages. So it means that for sex workers, it's to access the healthcare without discrimination. Many sex workers avoid clinics due to stigma and mistreatment. The full decriminalization ensures safe, respect, access to sexual reproductive health rights services, and also it helps with HIV prevention and treatment. Criminalization limits the condom use, outreach, and health education. Decriminalization creates safer environment for prevention and care. We also suffer with mental support, health support, constant fear of arrest because sex workers, they are afraid that there will be shame of harms and on their mental wellness. So SGD 3 includes mental health. Sex workers deserve safety and peace of mind. When it comes to SGD 5, we have to achieve a gender equality and empower all women and girls, which means that sex workers, what does it mean for sex workers, right? It means that bodily autonomy. Criminalization takes away a woman's right to choose what she does with her body. But full decriminalization supports freedom, choice, and control. Ending gender-based violence, sex workers face high level of rape, assault, and abuse, often from police or clients. Decriminalization allows sex workers to report violence and access justice. Trans and queer inclusion. Many trans women and queer people do rely on doing sex work to survive. So gender equality means all genders and identity, protecting all genders and identity. Sex work remains criminalized despite being deeply linked to public health and human rights. Sex workers are already part of our health and education system as per educators, activists, mothers, and caregivers. To achieve the SDG 3 and SDG 5 by 2030, we must decriminalize sex work and fully and immediately. So when we are on SDG 5, it shows that decriminalization is still the most powerful move. It removes legal barriers to health access, justice, and human dignity. It lets peer educators and health organizations do their work without fear. We also need people to invest in peer-led healthcare and outreach. Sex workers trust other sex workers. Scale up peer education, HIV testing, PrEP access, mental health support, and mobile clinics. This supports both well-being and empowerment. And then we go to train police and healthcare workers, sensitize police, clinic staff, social workers to treat sex workers with dignity, ending profiling, violence, and forced HIV testing, make public services safe and inclusive. Include sex workers in national policies. Include sex workers in all gender-based violence, sexual reproductive health, and HIV strategies. Pay sex workers for their time and expertise. Remember, nothing about us without us. Number 5, we tackle poverty and unemployment, right? So we need to link sex workers to job, housing support, and social grant. If they choose to exit, empowerment means choices, not pressure. Many trans and queer sex workers face many double discrimination already. So we must always remember that the full decriminalization of sex work is the best move for sex workers. Thank you.
Thank you very much, Pam, and thank you for talking about decriminalization of sex work and making them part of the mainstream community and people. Thanks for your very, very important insights. And I will now invite my fellow sister, resistor, and persister, friend and guide, Abhina Aher. Abhina is a noted transgender rights activist. She chairs Asia Pacific Transgender Network, or APTN, and leads the Tweet Foundation, which is Transgender Welfare Equity and Empowerment Trust India, as its Chief Executive Officer, and plays a key role on many organizations, committees, and spaces. Welcome, Abhina. Over to you.
Thank you. Thank you so much, Shobhaji. This is really helpful. So I just wanted to sort of, my topic is specifically, my name is Abhina Aher. I'm right now not a chair of APTN, but I have served. I'm a former chair of APTN. I've worked at the regional level with APCOM as well, as a senior officer. And I'm glad to be here. And I was listening to Eamonn, the fantastic data that he shared and the resilience of the act that we need to do on an immediate basis right now when we talk about the transgender and other key populations issues. And, I echo that, and a big thank you for all your leadership in the region and providing us all the supports. Today, I'm going to talk about specifically on the transgender rights from the perspective of SDG 3 and SDG 5. I just want to acknowledge at the beginning in itself that, we cannot talk about SDGs without communities who are transgender people. Unfortunately, we have been, submerged we have been sidelined, and we have been, diluted within the larger spectrum of LGBTI people. Trans organizations, trans institutions, trans work, trans individuals, trans advocate do need to have their platforms and their opportunities to talk about their human rights. And also, I don't think so we can really imagine SDGs without the transgender people. We're talking about a 2030 agenda on sustainable development, and it does talk about a very, very clearly a strong statement that says that you cannot leave anybody behind, especially for the people who are left behind because of their gender expressions, because of their socioeconomic status, and because of a huge amount of separations that they have received outside the community from the society and inside the community within the queer communities as well. A lot of LGBT organizations does trans work, but they do not give an empowerment and engagement to the transgender leaders. And that's a sad part about it. And that's the reason why today I'm here to talk about a trans leadership and trans organizational leadership, which is very important within the within SDG achievements, especially making sure nobody is left behind. We all know that when we talk about health, though we talk about HIV, though we talk about SRHR, though we talk about HIV, HPV, we talk about several issues that are impacting to the transgender people. But mental health is one of the undermined issue that people are not being able to talk about enough. And, the data clearly shows that, almost 2 to 4%, there is a huge amount of, there's a huge amount of concerns that are there when it comes to the mental health risk for the transgender people. And and all these things are connected, because when we talk about sustainable behavior, we have to talk about mental health illness among the transgender people, mental health issues among the transgender people. HIV is a big issue, and right now Eamonn also talked about it. Everybody's talking about it, how transgender women, transgender people, transgender men also, because we don't have a trans masculine HIV data. Though we talk about it, the anecdotal experiences about across the globe, 1% of transgender masculine people are also impacted by HIV. But still we don't have a very solid data. So there's a data which is missing on the transgender people. There are researches which are missing on the transgender people. There are cross-sectional studies which are missing on the transgender people. And many times we are missing from the SDG dialogue, which is a major concern about it. Estimated population globally, when we talk about, is it up to 6%? About that in countries like India, the census, which is done almost 10 years back, talks about 0.4 million population. But the fact remains is that the statistical information of UN talks about it, that in any given country, in a population which is sexually reproductive, 0.1% to 1% population always identify themselves as a transgender people. So we are there, but we've been seen transparent. We have not been given an opportunity, and we have been always missed on the important dialogues and discussions. Now, when we talk about SDG 3, SDG 3 talks about the good health and well-being. We're talking about, there are a lot of studies, and I think India also has a white paper on transgender people, where there are a lot of interventions and preventions have happened, and all of them like shouted from the top of the hill, saying that transgender people need holistic health response. Transgender people need to have a centralized services like a one-stop shop, which is a very important aspect and which are missing right now, because transgender people have to run from pillars to post, and many times transgender people are surviving on sex work, they are surviving on begging, they are surviving on traditional businesses, and they don't have the resources, they don't have the awareness, they don't have the support, the peer support that is required for going and accessing the good health and sustaining on a good health. And many times transgender people struggle with the self-stigma. It's like a stigma onion. So like, for example, I'm a transgender woman, but I can be married to a woman because of the family pressure. I can have children, or I can be living with HIV. I am a TB survivor. So there could be multiple stigma that can really impact impact the transgender health, we really need to understand about it. And within the SDG 3, of course, we are talking about HIV in a very important manner, but I think we should not forget about another issues that we talk about, the triple elimination about the eliminations of HIV, STI, and TB on one go, because we don't have enough resources right now, and we have to leverage from the program. We have to do the intersectional work, which is very important aspect for the communities like us, which are impacted by various health aspects. Mental health, sexual reproductive health, universal health coverage is a very, very important aspect. Now, many times when we talk about it, that policies don't change the mindset of people. So on the policy, there will be written saying that transgender people should not be discriminated. But we face stigma discrimination at the doorsteps of the healthcare services. And that's a real fact. That is what all of us go through everywhere. There are a lot of transgender people who have been thrown out from their workplaces also just because they are transgenders. A lot of companies. I have lost my job. I was working with USAID. I've lost my job just being a transgender person. A lot of transgender people have lost their job. Transgender people are under the threat. Transgender people are right now left to die. And that is the harsh reality that we are supposed to talk about it. There are a lot of evidences that highlight those issues very predominantly. But my organization, Tweet Foundation, Transgender Welfare, Equity and Empowerment Trust, we have done a fantastic research with the trans masculine identities and transgender people, and we have found out that 71% of transgender people are facing the problem in accessing public health services, and 53% actually were never tested on HIV or STI or UTI related matters. So that's a matter of a concern. SDG 5, when we talk about the gender equality, we have to talk about all sorts of discrimination. Unfortunately, there aren't any public campaigns that talks about gender equality. People, when they talk about gender, they normally talk about small women, girl child, or cis women. They don't talk about transgender people. Within transgender people also, you have sex workers, you have disability transgender person, and many times those discussions don't go to that level when we talk about ending discrimination just beyond a normalized gender, which is a binary in nature. And that is something which is a very important aspect that we have to talk about, is that we have to talk about the legislation. The policies are not there, and we are trapped into vicious circle of data scarcity. Why am I saying vicious circle of data scarcity? Is that because we don't have enough data. When we don't have enough data, we are not been able to influence the policies. When we don't have policies, we are not been able to stop the discrimination. And the transgender people who are facing the healthcare discrimination 10 years back are still on the same platform. And we really need a big push, big investment, and big empowerment of the transgender community at this point of time. Challenges, there are so many transgender related challenges that are there, especially because transgender people are extremely criminalized. In India, when they talk about creating services for transgender people, first thing that they did was they created a transgender jails. Can you believe it? They should have given a food to the transgender people. They should have given a social welfare to the transgender people. But the first thing that they try to talk about is that creating a separate jail for transgender people, which is a fact, because a lot of us are seen as criminals. We are not part of a society. Nobody invites us for their Christmas dinners, and nobody wants to get married or set up a families with us. That's a harsh reality that a lot of transgender people are facing. And our Indian data itself talks about it, that only 6% of the transgender people are right now going through a formal recruitment process. Many times when we talk about legal and policy landscape, when it comes to the SDG related discussions, there are a lot of laws and global guidelines that talks about that, especially by WHO, WPATH, UN. Thanks to UN, who has done a lot of good campaigns on highlighting transgender perspective related data. And also there are a lot of Indian evidences that talks about social welfare support, healthcare related guidelines, and also educational and other related support. In fact, the government of India runs a shelter home. We are running one of the shelter home in India, in Mumbai, which is very, very important for transgender people because they are being thrown out of the society. They don't have the dignified roof to live in. When we talk about SDG, I think we really need to understand that most SDGs national dashboards do not include the indicators on transgender persons. Their indicators are with women, men, and children, adolescents person, young people. That's it. It doesn't go beyond to that. And I think there are times when we have really created a hue and cry about it, but still we don't have enough indexes that captures transgender specific data. These are some of the evidences that I am highlighting to you, which are trying to capture the transgender related data, but we still don't have a holistic trans data. And this is big time missing. So I think the recommendations when we talk about it, of course, we have to talk about data and indicators that truly captures the SDG inclusion on the transgender people, on health, education, employment, and of course on gender-based violence, which is a very, very important aspect. There are tools which talks about health surveys, census, and various other health-related MIS systems which can capture the trans-specific data, but we have to do an active work on that. I think the big piece of work which is missing out when it comes to SDG is with the young people, young transgender people and adolescents transgender people, because a lot of bullying are happening at the schools and educational levels, and there aren't any good amount of data on that. There aren't any good amount of data on transgender death also, or murder cases also. I remember some time back, TGEU had tried to capture that data. But what we are talking about is that we are talking about meaningful data, and within that meaningful data also has to be captured by the transgender people. Unfortunately, the pie which is served for transgender people, non-trans people are eating that. And that is the biggest concern that we have. It is not serving any empowerment to the transgender individuals. We need to have a bigger and better advocacy. We really need to have a voluntary national reviews on transgender people of understanding their situation. We need to create SDG linked to the government schemes. And we need to make governments accountable for SDG related matters on the transgender people. Transgender people has to lead this process. They should not be just the beneficiary of the same. And I think we need to really understand that trans rights are not just human rights. They are key to achieving global justice and sustainable development. We really need to sort of understand that trans people were always there. Trans people have led the LGBTI movement across India, starting from Stonewall, and transgender people will never be erased. So I just want to thank all the trans warriors who've been making such a wonderful work, not only for transgender people, for key populations. I would like to thank UN organizations, USAID, Tweet Foundation staff who's been doing a fantastic job nationally in countries like India, Shobhaji, Bobby, and CNS. Thank you so much for this wonderful opportunity for me to share my experience. I truly appreciate it.
Thank you, Abhina. It's always so energizing. Yes, it is demoralizing also at times, but energizing at the same time to hear from you. And you are very right in saying that how can we achieve SDGs without inclusion of transgenders and raising their mental health issue problems and also the scarcity of data. I think these are the things which we need to focus more upon. Friends, we are sharing the Asia Pacific Forum on Women, Law and Development statement on feminists raising the red flag and demanding justice and reparation in the chat box. Be welcome to read it. I think it's worth reading for all of us, especially those in the media. And we now open for comments, reflections, and questions from the audience. Please type them in the chat box, and we will take up as many as the time permits us. There is a question from Mona Yadav, who's a gender activist and a psychologist from India. And her question is to all the speakers, that what kind of psychological support and interventions can be provided for people living with HIV? Is there any data that can reflect better treatment results for people with HIV who receive psychological support? And as that can also reduce stigma. So would the speakers like to comment? It's directed to all our presenters. The question is for all of them. Eamonn, would you like
Hi, can I? Okay.
Yes, please go ahead. Yes.
Okay, thank you. I think we really need to understand that PLHIV people, especially from the key communities, go through anxiety, fear, and depression and denial about their entire HIV perspective or HIV status. I think we really need to have programs that trains the healthcare providers, counselors, the activists, and the community leaders who are living with HIV open and out as a great example. And I think programs should be focused on training. I also feel that there has to be a stronger program on peer support, especially for the communities who are living with HIV and they are from key population. Because in countries like India, I think we give the biggest numbers for HIV. In a region, and I think we still lacking with the peer support. The PLHIV organizations are still need to bring in young people, young PLHIV movement for creating important issues, and we need to look into the programs that are custom made for the artificial intelligence or social media or digital intelligence, which will be more cost effective rather than cost intensive. So I think the programs needs to be talk about like the new age generation program implementation. There has to be a family centric approach also. So like for example, when I was doing a program with PEPFAR, we had a very fantastic, very interesting program that was specifically looking into the family health. And I think it was specifically helping the families to ensure the adherence, to have a sustainable health approach. And the last thing I want to talk about is that the sustainable health approach. So, making sure that you have a lifelong therapy support for the transgender people. There should be a policies like HIV Act, which is there in India, which are supportive to report on discrimination, important. And I think the program must and has to highlight on public-private engagements to create bigger opportunities and bigger potential, like a satellite clinics or satellite spaces where transgender people or PLHIV people, PLHIV transgenders can access the ARV and other services, especially in the rural areas, especially in the hilly areas, especially in the areas which is been hit by the climate related aspect. And I just feel that intersectionality is key. Right now, with the limited resources and the resources are drying up, I think we need to have more intersectional program, and we must not forget about HIV and TB infection, because the higher mortality is happening because of the HIV and TB. Thank you.
Thank you very much, Abhina. And I think that also answers Letizia Diam's question. Letizia wanted to know how can we accelerate work for transgender people in India and other countries too. So you have spelled that out very clearly here. Eamonn, would you like to add something?
I think Angelique was going to say something first, Shobha. Angelique, you go first.
Sure. Thank you so much. I just wanted to share a couple of things. I think I put in the chat with my resources, but I'm putting it here again. Something that CAISO has done. First of all, just to share our work with CAISO, that the communities that we focus on, primarily because we know the intersecting ways that people experience discrimination and stigma, include not only LGBTQI plus people, but also people living with HIV and people engaged in sex work, regardless of sexual orientation, because we understand how sex and gender discrimination impact our communities and folks who do this kind of work. And so people living with HIV, one of the things that we've done, I mean, absolutely, it's so important to have supporting mechanisms. We have engaged with things like support groups for our clients and for community members, creating spaces for people to engage and be able to support each other through their process. One of the challenges, and I've added this HIV toolkit that we created that is sex positive, and that is specifically for LGBTQI plus people and thinking about mental health, because we've recognized the ways that actually can prevent adherence to treatment. And even though in Trinidad and Tobago, access to HIV medication is supposed to be free through the public healthcare system, the stigma and discrimination that people experience, especially for gender nonconforming folks, for trans people, and for people engaged in sex work, there's so many barriers to accessing one's any kind of healthcare through the public healthcare system. Of course, if you have money, this is a class issue. If you have money, you can go to private doctors, but I'm talking about the public healthcare system. So what we've done is this toolkit was one of our interventions. And also we have a peer navigation system where if someone doesn't want to go to a clinic to get medication, we offer support in being able to get that medication for people, especially for our clients. And another thing that we have been doing is advocating for PrEP. We say it every possible place we can. Trinidad and Tobago is supposed to have, in other places in the Caribbean, PrEP is more readily available, but it is not as accessible here in Trinidad and Tobago because the past Minister of Health over the last 8 years has insisted that it, in quote unquote, increases risky behavior. And so you have to go and disclose partners before you can actually get prescribed PrEP. So that's been a huge barrier for people being able to take there. So that's another thing that we've been advocating for is accessible PrEP access. So those are just a few things I wanted to share. So these things are important. I think absolutely the community work and destigmatizing it remains essential and talking about it as much as possible. Thanks.
Thank you. Yes, Pam. Pam, you have raised your hand. Yes, Pam, please go ahead.
Okay, thank you so much. We also, sorry, a little bit. We also do offer we do have counselors, HIV counselors that are trained to work with people that suffered from trauma, grief, HIV, stigma, and mental health. We also do one-on-ones, group therapies. We also, our peer educators, they do get trained to do referrals for people that have mental health. And we also offer GBV and trauma support. Also, we work with stakeholders, which is Lifeline South Africa. They do a 24/7 counseling hotline. They offer as well. They offer trauma debriefing and emotional support for those living with HIV. Also, Sisonke, the Sisonke National Movement, which is under our umbrella, which is also a peer-led emotional support circles. It also offers safe spaces for HIV-positive sex workers to speak freely. There's trained members who offers psychosocial guidance and coping strategies. We have other stakeholders, which is Sonke Gender Justice, which works with vulnerable communities on gender equality and trauma support, helps sex workers with dealing with intimate partner violence and internalized stigma. We worked with TB HIV Care, which provides mental health. We used to work with Vets RHI before they lost their funding, where they offered PrEP, they offered PEP, they offered HIV testing, and also they offered to trans people, they offered what is this thing now? For hormones, I forgot the name, the thing is the name. So they also offer that. We have like a long list of stakeholders, which is also ANOVA, and we have Lifeline, which is SADC sometimes, where they offers national support when it comes to trauma counseling in people that are injecting drugs or just people using drugs, and also with Legal Resource Center and also USARC, right, where they do trauma or violence. So thank you.
Thank you very much. Now there is Eamonn. There is another question for you, and we would like you to come online. Salma Patel wants to know, how can we end criminalization of key populations? Because they are also part of the solution, engaging them. And unless we do this, how can we deliver on SDG 3 and SDG 5?
Right. Thanks for the question. I saw there was another one too about
Yes.
the Geneva consensus. Thank you.
Yes.
Yeah, so these are all interconnected. You said it yourself, Shobha, earlier. There is a very well-resourced and global campaign against rights of a whole range of sorts, not just about HIV or key populations, women's rights, all different rights. So there needs to be a number of things. What can we all do? And we all have different roles. There's no simple solution for this, of course. So advocating with governments to recommit to the Beijing, the ICPD, the CDAW, Global AIDS Strategy, to give the acronym soup, but many of you will know them very well. To amplify progressive narratives, that's one of the most critical things we can do. Not just accept it, but let's come out with some of the alternative narratives, leaning on the global and the South-South coalitions, the expertise that is vested in communities in countries across the world, and that intersectionality Abhina just talked about again. We've got to get some of these issues together. They're attacking women's rights. They're attacking rights of LGBTQI plus populations. But if we deal with them separately, we're not going to get there. We need to come together and form new coalitions to push back. And so that's where we need to be thinking differently and more strategically. We got to highlight the public health impacts and document rights violations. Some places there are public defenders that can help people respond to criminalization of different sorts. So we've got a number of these issues to do. The challenge now, of course, is resources and the cut in funding. And that's not just from one big donor or other smaller donors. That's within countries as well, the domestic resources and the pushback on civil society having a role. So that's going to take some rethink, and it's going to take a bit of a collective action to push back. And we've seen some good examples of that. Changes in legislation. We heard Angelique talking about then the comeback on that. But then we fight again, and we'll see progressive change. It's not going to happen overnight. But you're right. Unless we get that out of the way, we're not going to see people coming into services. We're not going to get the benefits of U equals U. And the last comment, Shobha, self-stigma is one of the most critical issues we deal with. And today we need online services, cheaper services. Somebody's asking, how do we deal with the cost cutting? We're going to have to look at new service models that are going to be effective and cheaper to reach people, be that for mental health. We know the spiritual health as part of our life journeys is what helps us deal with some of the most significant human health or other issues that we have to deal with. So I end with that. I think these are critical ways. And it's that forming new partnerships, new groups, women's activist groups coming together with PLHIV groups. They have common issues. So let's stop working in isolation and come together and use the collective power. Thanks.
Okay. Thank you. Would any of the other speakers like to add to the questions that have been asked? Zafar Kidwai has a comment. Zafar says it is good to read that Cote d'Ivoire increased domestic financing as well as funded UNAIDS too. Do we hear or will we hear such news from other nations also? Because sustainable financing is important. Yes, Eamonn.
Yeah, I missed that one. I saw that. That was great. I was in a meeting yesterday and I heard a number of countries. Morocco is putting in funding because people may know our own organization, like we heard from Abhina. Community organizations were the first to lose their funding. You know, for us, it was a slower because we had other resources. But now we're cutting our staff across the world by about 50+%. And so that's going to have an impact on our advocacy work on behalf and with communities. So there are countries. Cambodia has just put in 100,000. That sounds small, but if we have a lot of countries putting in resources, that's over and above their domestic investments, which they're increasing. Thailand does it, a number of them, but some of them are really ramping it up and increasing. You would know, Shobha, India funds 95, 98% of its national response, right? So there are countries that are out there doing it. Some are far, far behind where they should be. And that's where we're advocating heavily that they really need to pick up the ball there, because we can't rely on international sources. Thanks.
Thank you. Thank you very much. And I think we have just overcrossed our time limit. So with this, we come to the close of today's She and Right session. Thanks to all our speakers and participants for their invaluable support. And I'm sure all of us are going back with a lot of learnings from today's session. I would also like to thank many of you who are part of this session today and were part of Asia Pacific Regional Civil Society Engagement Mechanism, or APRCM, and Women's major groups for supporting me to be the lead discussant on SDG 3 at the recently concluded UNHLM in New York. My statement and input was rooted in the consultative process of APRCM that led to SDG 3 fact sheets earlier this year. Both HLPF 2025 and FFD4 have failed our communities. With only 5 years left to deliver on SDGs, not only progress on human right to health, gender equality, and human rights is off the mark and off the track by miles, but also receding in so many aspects. We need to unite and demand both structural changes. And the call is clear. We want development justice now for a feminist world order. And I would once again like to tell you that those media persons who are reporting on issues raised by She and Rights, please be welcome to apply for She and Rights Media Awards. The link has been shared in the chat box. And till we meet again, have a good day. Thank you.